Hello, so my name is Helen Bulbeck. I'm Director of Policy and Services at brainstrust, the Brain Cancer People. We are a very patient and caregiver facing charity and have UK-wide reach. And our goal is for anyone living with a brain tumour to be able to have their best possible day. We are for a world where people with a brain tumour are involved, they feel resourced and supported so that they're confident and feel connected. They're living the life they want because they're people first and patients second. And this is going to become increasingly important as people are living longer with primary cancer. And we now know that 40% of cancers, or up to 40% of cancers, will metastasize. Doubling and trebling of therapies too, and combination treatments mean that quality of life is being increasingly foregrounded. So what I'm going to do in this brief talk today is talk about bringing patient validity and experience and relevance to the agenda. It's about hearing a patient voice in a complex system. Effective measurement and evaluation of health-related quality of life provides impact and insights into the human condition. Used effectively, they can shift the metrics from preserving life to enhancing life. They can develop and drive service delivery, improve relationships, save money, and build resilience and resource in the community. We're only empowered by the information when we understand and realise it. And currently, there is a gap between the information about genomics and chronic diseases that researchers know and share, and the understanding of this information among people who are living with the illness. And unless we close this gap, we cannot make the right decisions about our care, we cannot be co-pilots, and the knowledge power base will stay with a small body of experts, and this isn't in the best interest of anyone in the community. The patient is the expert on them, what their values are, what their context is, and what their appetite for risk is. So I'm going to explore some of the challenges we face when trying to measure patient outcomes, and also the opportunities that this can bring, because we haven't got it quite right yet. So we believe that science and medicine have a duty to understand the consequences of treatments that are delivered. The thrust of integrated care systems is towards system-wide outcomes measurement, but there is a case to be made too that this loses sight of what is key to this, the person living with the disease and what matters to them. There is no story to be told without the patient. The patient is the only form of data, and the value the patient brings to the agenda exceeds that of the purely clinical. A genotype does not explain how a person perceives their health state, what motivates or stands in the way of behaviour changes, or what other life events and stresses are competing with the ability to maintain health and well-being. Currently, we have numerous ways of measuring the quality of life, but very few of these measures come from the perspective of the person living with the disease. With a focus on the person, we can set about reframing the problem of measuring quality of life so that we're measuring the presence of health and not the absence of health. But to get to this point, patient involvement is key as quality of life climbs the agenda. We know that patients can misimagine their future state, and this has significant bearing on decision making. They have the experienced utility of their current symptoms and imagined the future utility or disutility as they live with the disease. People living with the illness can anticipate alternative futures by hearing the experiences of those who've preceded them. You take what is least valued, death, and what is most valued, symptom relief, and then take into account the different wants and needs, the social context, the core values, and the person's appetite for risk. Patients are the expert on them. They value things differently. What is possible is the clinician's role, and what is preferable and valued is the patient's role. And having patients as co-pilots reframes problems, generates insight, shifts dynamics, changes practice. But all too often, with the measurement tools we currently have, we see the target hit, but the point that is meaningful to the patient is missed. And this is nowhere more clearly elicited than in Andrew, who's the patient I'm currently supporting. Andrew's 42 years old, he's got 3 teenage children, recently divorced, but more importantly, has been recently diagnosed with a glioblastoma, the most aggressive of brain tumours. This has impacted on his life in ways that are unimaginable. He's lost his driving licence, he can't afford child maintenance, he's in rented accommodation, he cannot accommodate his children when it's his time to have them. He's remote from his brother and his parents, who live geographically quite a long way away. So he lives in a permanent state of heightened emotional stress and is unable to function properly. He's got the challenges of disease trajectory. He knows he's going to have progressive neurocognitive and neurological decline. He's got the high symptom burden and the pressure of teleological time, the sense that time is running out. He doesn't have a team around him. He's living with uncertainty, and every single conversation he has is focused on treatment. So how do we close the gap between genomic research, which is clean, tidy and focused, and the lived experience with the human element, which is messy, chaotic and broad? And I don't see much space for Andrew on this pathway. Where is the space for him to talk about what matters to him, let alone research? The closest he will get to this is a nurse completing a holistic needs assessment with him. And all this really does is reinforce what he can no longer do. We know from our daily interactions with the brain tumour community that they want 4 things. They don't want to feel despondent. They want an understanding that brain cancer is unique. They want to feel resourced, and they want to hear a conversation that is a move from what's the matter to what matters to you. And if we ignore the patient voice when measuring outcomes, we have a disconnect between the epidemiology of disease and the epidemiology of healthcare. Our experience is that the epidemiology of disease focuses on overall survival and progression-free survival, but patients want to focus on quality of life, function and symptom relief. And that's where shared decision-making comes into play, because this allows everyone to become co-pilots in their care, so that we see a new model of maintenance of wellness as well as the treatment of illness. And we're really excited that the NICE guidelines for shared decision-making were published on June the 17th last month. So gathering data around health-related quality of life is in its infancy, but we've seen sustained interest over the last 20 years. The approach, however, remains fragmented with no real strategic overview. This is only going to become worse as more people are diagnosed with metastatic brain cancer as they live longer with primary cancer. We know, as I said earlier, that more treatments are being trialled, which brings more potential morbidities. Doubling and tripling of therapies means that health-related quality of life will need a paradigm shift. Across all cancers, we have clinical uncertainty around data quality and a lack of public understanding and trust about how data is collected, used and stored. There's a heavy focus on outcomes and a lack of clarity about what it is we want to know. Path dependency too is an issue. With personalised medicine, people do not follow the same pathway for their disease. It is no longer one size fits all. Brain cancer brings its own challenges. Brain tumours constitute a less common cancer group with complex effects on both patients and their caregivers. High rates of physical and cognitive morbidity differ in nature to other cancers and may require alternative supportive and palliative interventions to address both the impact of the tumour and its treatment. It comes with a high attrition rate. The symptoms cover a broad spectrum. At one end of the spectrum, people can exhibit apathy and indifference, and at the other, egocentrism, disinhibition and aggression. We know through research what the problems are, but we're still novices when it comes to understanding what the impact is. We find it hard to disaggregate what is tumour effect and what is treatment effect, and there is too the uncertain trajectory. Decline can be insidious over time or happen very quickly within a few weeks. Yes, we do have validated measurement tools, but none of them do everything, which mean that multiple assessments have to be done in a variety of forms. And so for the analysis and interpretation of health-related quality of life measurements, low compliance and missing data are methodological challenges. It's a big ask of someone who's living with a life-limiting prognosis, whose mental capacity may well be compromised, and who is facing progressive cognitive decline, to keep filling in a multitude or multiple range of health-related quality of life assessment tools. So what would we like? Well, we'd like to grow the conversation. We'd like to see a shift from what does the average patient need to know to be able to make an informed decision, to what does this particular patient need to know and understand to be able to make an informed decision about their healthcare. And how do we go about closing this gap? Well, new research paradigms are changing the way we collect, measure, evaluate, and act on the data we have, but this is in its infancy. Many of the existing outcome measurements have not been designed for the sort of population level outcomes we need, nor do they reflect local levels, subsets or key groups of patients, or even what matters to them. Much of the data we need to be used lies in care data systems, as well as those that exist in acute and primary care. We now have a combination of individual biomarkers, population-wide comparison data sets being mandated, all of which should be transforming clinical research and care into a new paradigm. In this new world, we become responsible for monitoring our bodies, noticing deviations from trends and making appropriate changes. Using this paradigm allows for us to become co-pilots in our care so that a new model of maintenance of wellness, as well as treatment of illness, as I've said earlier, becomes the norm. We see this in the number of health apps that have flourished. Digital health has developed into a sound business, attracting players from various industries outside of healthcare. But inevitably, there are headwinds to this: access to local resources, looking at the joy of local, what is available to the patient and their caregiver. There are mindsets too. The fact that patients still see the NHS as a patriarchal system where you have a problem, so you go and see a paid professional and you expect that person to fix the problem. There's a shortage of resource, and funding, we know, is an issue. And then there are issues around data, aggregating smaller data into big data and back into personalised small data, analysing big data in appropriate clinical, social, environmental context and drawing scientific conclusions which show validity. And challenges around understanding the range of scope of data that exists. We have oceans of data, but only puddles of meaning. We know too that data is bound in silos. There are issues around security. There's a lack of technological infrastructure, and also data being regarded as a proprietary asset. So how are we going to change this? It's about developing agency in people living with the disease, so that they become co-pilots in what's happening to them. And we are now developing a core outcome set, the COBRA study, which is patient-reported core outcomes in brain tumour trials. For the reasons that we've elicited already, we need a consistency approach in the types of measurements used across trials and units. We need accuracy in matching those measures to outcomes expected of an intervention. And we need diligence and compliance in data capture, analysis and reporting. So this is work that's being led by Anthony Byrne from Cardiff, and there are two steps to this. So first of all is to define what a core outcome set, which should be measured across all UK studies in high-grade glioma, and then defining the methodological approach required in designing brain tumour trials, which will ensure that patient-reported outcomes are administered at the most appropriate time points and are analysed appropriately with a hypothesis and statistical plan for handling missing data. Technical and governance functionality will be created, which will allow sharing of patient-reported outcome data between studies and across units. And this work is also going to embrace the emergent international consensus. So we're starting with a systematic review of patient-centred outcomes identified as of importance to people living with a high-grade glioma, which will also include their caregivers. This will then inform the second part, the development of the core outcome set, which is specific to high-grade glioma research. The core outcome set protocol will be registered with COMET and will be publicly available. And from the patient's perspective, it's about developing agency in people living with the disease. We need the tools, networks and license to be people first. And this will take considerable investment in technology, new tools to aid decisions and a change in culture for everyone. And genomics needs to be in the DNA of this transformation. We need to develop influencing factors to shift from passive participant to active participant when you're diagnosed with a brain tumour. We need to demystify the complexity and sophistication of the biology, the design of trials. We need to build resilience in the community so that we're comfortable with uncertainty, which is not the same as feeling unsafe, about understanding risk, context and values. And we also need to see a shift from randomised controlled trials to real-world evidence, from can it work to does it work, from ideal conditions to real-world conditions that reflect a human dimension, from fixed regimen to flexibility and agility. It will be messy and broad because it involves the human condition. The scope of the work is only going to increase as we learn more and more about disease through genomics. So we need to move away from public involvement as an intervention that has a measurable effect and recognise continuous reflection as part of the research process. We should see patient and public involvement as a social practice of dialogue and learning between researchers, clinicians and the public as an end in itself, not merely a means to an end. We too need the experience to be different to what's gone on before. We need the research to be defined not only by its ambition, progressive therapeutic thinking and cutting edge practices, but also by kindness, empathy and support. So we're not done yet. Where does this leave Andrew? Well, eliciting from Andrew what matters to him, what his values are, his context, his appetite for risk would be. This would be a transformative conversation for him and his team. It would place him as a co-pilot in his care. He'd be regarded as an asset with his own sense of resourcefulness and a range of capabilities. He would be more able to engage with research, recognise this as a person-centred process so that quality of life becomes just as much a rich theme in research as a search for a cure. And this isn't, sadly, going to happen in his lifetime. And most importantly, we'd have a good story to share, which means we could take this forward and continue to change the agenda. So thank you for listening to me today. If you've got any comments or feedback, then please don't hesitate to email me. Thank you very much.